Right, good afternoon, everyone. I think we'll kick off. If people join, that's fine. We'll just try and make sure you're all on mute for now. Um, Now, my name's Terry Huff. I work for AGEM, and today we're gonna talk a little bit about connected planning. I've been working with colleagues in AGEM and across other NHS organisations to see how we can improve productivity with better integrated planning using some of the technology that's currently commonplace in other sectors, but not so well used in the NHS. So today, I think we're hoping to give you a bit of an insight into the work we've been doing with some of our fellow NHS colleagues. So do we just want to switch? Thank you. So today we're going to do a little very brief introduction about AGEM and what we do for those of you who are not aware of what AGEM does. Then talk a little bit about what we mean by connected planning, and then we're going to look at the challenge that we were given by one of our care systems, and looked and that was around performance and temporary staff in an A&E setting. So that we're going to be looking at that as the challenge. We're going to give you a very brief demo and then talk a little bit about the benefits and finally leave some time for questions and answers at the end. Now, so you don't forget any of your questions as and when you get them, it'd be really helpful if you could put them in the chat as and when you think of them, and then we'll try and pick up all those questions at the end of the session. This is only a half hour. It's only a half-hour demo. It's really just a taster. So if any of you again want to hear a little bit more about this, there'd be an opportunity to contact us after the meeting, and we'll also be recording this so that we can push it out more widely. So it'll be on our website. And if you want to share, this recording with others, yeah, please feel free to do so. So AGEM, what are we? We're sort of the back office that supports the NHS. There's four of us that cover the whole of the country. We now make up almost 7,000 staff with a £500 million turnover, and some of the services we provide relate to data and data analytics. You may not be aware, but we actually provide a lot of the data management for the NHS, the acute data, primary care data, some of the community data. And we even move data for the Department of Health between ourselves, health service, and local authorities. So we've got a real expertise in data management, which is one of the reasons why we started to look at how we can better use data and how we can better join up these data sets for better planning, both from an operational level and also at a strategic level. So next slide. So what do we mean by connected planning? Well, we do a huge amount of planning in the NHS, but it's often done in silos. So we'll produce finance plans that don't necessarily link up with our activity plans, which don't link up with our workforce plans, and it's really difficult because those plans are all done in silos. Is to not only to triangulate them, but also to better understand how they influence each other. Because although they're developed in silos, there's a big interrelationship between all of those sorts of plans. So there's a huge problem we have in the NHS in trying to link them, better understand how those data sets are connected, and therefore some of the solutions we want to put forward, what impact they will have. So if we were to increase spend in a particular area or a particular patient group or a particular type of the workforce or a particular area within an organisation, what the knock-on effects are throughout that organisation and the rest of the system. So it's something we've been grappling with for some time. And so today we're going to talk about how we've addressed some of those connected planning issues. And when we're talking about connected planning, we're talking about not only how we connect performance, activity, workforce, and some of your resources such as estates, IT, but also how you connect it from top to bottom, how you connect some of your plans from a regional level, an organisational level, all the way down to a community or specific population group. And all this is done so that we can improve our population health, improve the quality of care, and also improve the use of resources and drive out savings and make it more sustainable. Now we know, because we use so many of these data sets at AGEM. There's a wealth of data there in the NHS, but we just don't use it very. We don't use it very effectively. We don't link it up. We don't make a lot of data-driven decision making on a holistic basis. We don't. It's very difficult to do that. And when we do try and do it, it's often using historic data and historic data sets, and it can take a huge amount of effort in trying to combine those data sets. So it's so if it is done, it's done very much on a strategic level. Very difficult to do that on a day-to-day basis. And if you do try and set up data sets that work on that operational basis or on a strategic basis, they often don't link up. So it's very difficult to see how strategic plans link into the plans you have on an operational level. And because we don't understand often how those data sets are linked up, it makes it really difficult to predict how the changes that can happen. So again, connected planning tries to look at how we use those data, historic data flows, and use some of the AI and machine learning capacity that now exists to spot patterns maybe that we in the past haven't been able to see, because the NHS is a hugely complex animal. It's really difficult to see how weather, how different population types, our age, how different resource inputs, such as different skill sets, different staffing structures, how all these impact on patient outcomes, on performance, and on productivity. But we now have tools out there that can analyze these data sets and look for patterns and use that to help us predict the future. Which, if you can predict the future, it means you can start to understand what interventions are required to make improvements. So the challenge we were given, we were asked to work in a care system. They wanted us to look at an urgent care setting. They're spending a huge amount on temporary staff, running into millions, and at some points in the week, over a third of their workforce was temporary. So it's a huge amount of money being spent in this area, both in number terms, but also because they lacked the ability to plan ahead. Sometimes we were placing these temporary staff at very short notice, which also comes with a premium cost. There's also a huge amount of work in the background being undertaken by finance professionals, workforce professionals, strategists, trying to link up various plans, and is a huge amount of effort done in trying to do that, and it's often very much out of date. It's often often very costly to do. So there's a huge problem. How do we combine those plans? How do we triangulate them? And as a result of that, it's very difficult to make those to see how those plans are going to impact not just on temporary staffing, but also on performance and patient outcomes. So that was the task we were given. Can we help them triangulate those data sets, make it much more easier and less cumbersome to make changes to those data sets, and do that almost in real time, and at the same and also drive out some benefits in reduced use of temporary staff, and also improvements in performance and patient outcomes. So we set up a number of stakeholder groups that try to capture all those different people from different areas. So this very much came from a workforce perspective. It was the workforce professionals that are interested in this. They wanted it for workforce planning, and they were frustrated that that their plans weren't necessarily linked to the financial plans within the organisation. So we held a number of workshops and started to grab a much wider cohort of staff and get them much more involved in this. So that was a huge benefit in itself, just getting people to talk to each other about the problems they have and understanding how their plans fit with other people's plans. And so we started to understand the problem a lot better, and then we started to build a model with our model builders using a tool that's called Anaplan. There are other tools out there, but Anaplan was the solution that we were using. And that starts to pull together all those various data sets. It grabs information in real time out of various data sets and starts to look to see how they're connected and whether or not they are connected. And next slide, please. So one of the things you can do very quickly is you can start looking at workforce plans compared to in the real world. So in your ESR systems, so we can pull data from there to see how many staff we've got and how much we're paying them, compared to your financial plans. And so there's you can start to reconcile them very quickly and understand the gaps and understand the issues that you have between what you're actually spending and what you plan to be spending. So that's a good start when you start drilling down into the organisation, understanding where those discrepancies are and what you need to do to address them. Next slide, please. And then we also look at we've got historic data on activity plans, which is great because again you can see how activity changes over time, seasonally, by the week, by time of day, and we can start to model. We can look backwards, and using that data, we can start to model forwards on what that might look going forward. So we can then start to see what the demand for services might be, and in an A&E environment, that's extremely useful. And then if you've got information around your staffing structures and how much you spend on staffing on various staff groups, and you've also got information around activity, you can start to look at implied productivity. You can start to see what links these two. You know, how does and if you bring in the performance as well, you start to understand how that can improve performance. So what happens when activity goes up and staffing stays the same? What if staffing increases? What if a certain cohort of staff increase? How will that work through? Because we often find the NHS, it's really difficult to understand when you're preparing business cases on what the impact of some of these business cases might be. And here you have a tool that can help you do that scenario planning. You can start to run those different scenarios through it, and you can reverse engineer it as well. You can say, if I wanted 95% performance, or what if I've only got this amount of money to spend, or what if I've only got this staffing cohort? You know, how would that impact on all the other data sets? So how would changing one data set impact on all the others? And so you can start to look to see what's the most improved. What's the way of getting the biggest improvements in performance, or what's the biggest way of getting the most activity through a system? So you can start to model that and play with that, and that helps support that business planning process. Now I've done quite a lot of talking, so we're now going to show you a little demo for 5 minutes, just showing so you can still some real live slides of what we've been doing in this health and care system.
This is a brief video demonstration of Ardent & Gems CSU's approach to connected planning using the Anaplan planning platform. In this specific video, we do a deep dive into an example of an acute provider that is struggling with temporary staffing costs, and we'll look at how planning at different levels within the organisation can work together to help resolve this. For any further questions or for a more extensive demonstration, please send an email to agem.integrated-planning@nhs.net. Let's dive in. So as mentioned, this is part of Ardent & Gems' wider connected planning tools, which can look at other areas such as activity planning, productivity, sickness and vacancies. But for this short video, we'll be focusing specifically on challenges around temporary staffing. And a starting point of this might be an organisation wanting to understand the current position of temporary staffing plans. So within this organisation, we can have a view of their total spend on pay, and then the proportion of that spend that is going towards bank and agency staff. An organisation could drill down into how this changes across different sites within the organisation, of which they have 3 specific sites. And from this, they might recognise that 2 of their sites, Woodlake and Timberside, have a greater challenge around bank and agency spending. So from this, the organisation might first of all want to do some quite macro level scenario tests. So in this layer, what they can do is make some very simple adjustments to the size of the bank substantive and agency workforce. So in this example, what they might choose to do is make a 20% reduction to bank staff, a 70% reduction to agency staff. And as they make these changes, the planning tool will update to tell them what the impact of this is in terms of whole time equivalents and high level expected cost savings. However, the challenge is, although this is quite an easy to use kind of scenario modelling example, this realistically isn't the level of detail at which planning would happen within an organisation. But from this, they might get a sense of the level of changes required. So what we'll now do is we'll move into a more granular, in-depth example of how some of these strategic plans might be incorporated at an operational planning level. And what I'm going to do first of all is illustrate this example that whilst an organisation may have a core live version of a plan, when discussing changes like this, they might want to do it in a ring-fenced area, or what we call a scenario test. So in this scenario test, we're looking at in-depth financial plans where adjustments can be made to specific cost centres, specific subjective codes, and we'll have a look at some of these granular changes. So we saw that Woodlake was one of these challenges. And what they might decide to do is to look at their current workforce spend on their medical workforce and then make changes to specific cost centres within this. So we'll use a quick example of the consultant grades. So within this, the organisation is expecting in their current plan to have 14 consultants working across A&E, and these will be made up of agency, bank and substantive. Now in this particular site, there's no agency, but there are 3 bank staff. So what they might choose to do as a scenario is from October model a reduction in the size of this bank staff. So we can see here they've made an adjustment to go from 3.2 whole term equivalents to 1. And as they make this change, they will be given an indication of the saving that would be realised as a result of moving this workforce to a lower volume. So a £70,000 saving per month as a result of a reduced reliance on bank agency staff. Again, this could be applied to a different cost centre. So if they wanted to look at agency in one of their other sites, potentially reduce this down to 0.5, they can make these reductions. Again, you have the ability to kind of roll up and down. So we can see from some of these changes that we've applied, we have reduced the total headcount by about 10 whole-time equivalents. But because we've done this to specific areas, that's resulted in a significant cost saving overall. We also do include an indicative element of what impacts these changes would expect to have on activity that can be delivered. So obviously by reducing the workforce available within an A&E department, you would expect a knock-on impact in terms of the number of attendances that can be managed by that reduced workforce. But this is a true triangulation of the size of the workforce, the cost of the workforce, and potential impacts on activity. Finally, we'll go into some of the more technical areas of the tool. So with a planner, you have the ability to choose what assumptions you would like to apply on this relationship between cost and workforce. So you could take an approach of applying agenda for change salaries, using actual data, or applying your own custom set of assumptions. And this can be useful if an organisation wants to get an indication of what would be the impact if the average cost of bank and agency staff were moved more in line with what substantive staff cost. So we can see here some quite dramatic differences between the cost of bank consultant staff and the cost of substantive consultant staff. So bearing in mind that a user might make these changes within a specific scenario, once they're happy with a scenario, a planner could then adopt this planner scenario into a formal part of their life plan. As mentioned, this was a very quick demonstration, but in this we've shown the ability to look at the relationship between temporary staffing workforce and associated cost at a number of different levels, but then ultimately adopt some changes at a very granular level and understand the impact of these.
Thanks, Claude.
This is a brief video demonstration.
Thank you. So as you can see from that demonstration there, you can go from a very high level to a very detailed level across across both activity, workforce, finance, also performance, and productivity. Now we've already used this tool before in the NHS, linking activity, workforce, and finance, and that alone has led to quite significant savings on agency staff and overtime in a particular setting. What's exciting about what we've done here is we've now added productivity and performance, so we can start to model what the impact will be on performance figures, and also see what the implied productivity is, and how, and whether we can do things to change the productivity metrics. So these models are starting to get more and more complex, and the benefits of that, just looking through this, are as we've just discussed, it helps with the allocation of staff resources going forward, and offers potentially significant savings there on temporary staff. It also hugely reduces the amount of administrative time trying to manage these plans. There's a huge bureaucracy in putting these plans together, only to find that they don't triangulate. So the fact that everybody's using the same version of the truth and they're always linked is a huge step forward in reducing some of that administrative time. And also, if you start to use, we haven't put it in here yet, but we want to start to use the predictive modelling capabilities more. So this has only just gone into this care system, and if you can do that, you can start to see 6 weeks ahead, 6 months ahead, a year ahead, and that helps with your planning for your workforce changes over a much longer time on some of your workforce strategy. But it also helps you with things like bringing in temporary staff. So there's always going to be a need for those temporary staff, no matter how well you plan. But the sooner you can tell those agencies that you require them, the cheaper those rates are. And then finally, you've got all those additional benefits, I think, about that they're in that box there, around improving governance and accountability. You can start to see what the impact of your decisions are across the system, and you can start to hold people account for those decisions. And people have more confidence in the plans that they see, and if you've got more confidence in the plans, they're more easily to deliver. Thank you. So as our whistle stop tour through it, we've still got some time at the end for questions. I've just looked through the chat box. I can't see any have been picked up during the presentation, so it's really open to you all now to raise any questions you might have on the integrated planning tool. Francis.
Hello, sorry, I'm Frances Shattock from Herts and West Essex. Hi, Alison, long time no see. My question, so it's a really interesting tool. Has anything been done? This is all at organisational level, though. Has anything been done at system level? Because I suppose that's the unit of planning that I work with, is the system operational planning lead.
Funny up, in that same system, we started with another model which looked at the whole system. It was a bed flow, so we started to take the beds. Typically, we got a huge amount of granular detail in the beds in the hospital, but not necessarily much sight of those outside of the hospital. And if they're not managed as well in tandem, we don't recognise the relationship between the beds in the hospital and the discharges and where they go. That can lead to delayed transfers of care. So we've built a model that actually looks at the whole system, and it covers beds in mental health, in community, and we've also are in the process of just trying to put in local authority beds as well. So yes, that's looking at the whole system place. But the great thing about this tool is you can sort of add to it like a jigsaw. So the NHS is so complicated. So elsewhere, there's a model built there for at the Ambulance Trust. Well, we know that some of the ambulance trusts activity will flow into an A&E. So we could easily plug in that data source and link one to the other. So you can start to build out. So you can start at an organisation level and get some of the benefits there, and then you can build outwards. Or as we did with the bed model, you can start very big across the system and then work more detailed to an operational level in organisations. So it really depends who's buying the tool as to where they start with that use. But the ultimate aim is to link up all those different parts.
Perhaps I can just add a little bit to that. Absolutely, the demand and capacity models that we've got, you can scale them. We've just we're going to showcase one element of these models each week. So next week we're doing more on workforce next week, but we have got a model which integrates from place organisation through to a region and an ICB, and it actually looks at a fully connected model between workforce, activity, finance, performance. So we've got all of that as a sort of system-wide model, but we aren't presenting that today because we wanted to show some of the demand and capacity models. So we're starting with demand and capacity models, and then we move on to fully integrated system-wide models. But if anybody's interested in that, you don't need to wait for the webinar. We can just show it you on a one-to-one, really. It is all ready to go. Yeah, thanks. What we can do, actually, we'll just put the link to the other webinars in the chat if we get a minute, if Claude could help just paste those in. And then if anybody wants to share those with their other colleagues, like I say, we've got one per week, with a different aspect of planning, demand and capacity, workforce planning. We've then gone whole system planning. We've got even got a carbon tool that we're going to show you. So it's all aspects of resource planning. So, but perhaps if we can just pop that in the chat in a minute or two, the sort of links to the bookings on those other webinars, just to help share the good news.
Yeah. Okay. If there's no more questions, if anybody wants to follow up on this on a one-to-one basis, then you put your contacts in the chat and we'll pick them up, or we can do that or you can email us direct at the email that's sent to you through the invitation, and we'll pick up those conversations separately. Brilliant. Thank you all for your time today, and enjoy the rest of your day.